Now, as Sebastian explained, that the strategy of see one, do one, teach one is no more veiled strategy nowadays because of several factors have changed. The cut down of residents' working hours and the minimal or even non-invasive surgical techniques and surgical treatments for surgical pathologies. Adding to that, every day we have new devices, new treatment modalities, new surgical techniques come into the field. So all of this have decreased the exposure of resident to live surgery in the OR. And new compensatory mechanisms are needed at this time. We need to reach the level that we see one and simulate many and do one competently and teach everyone. Now, Yazergil also stressed this fact, especially dealing with delicate and novel organs, such the central nervous system. He always insists that residents should spend more time in laboratory studying the anatomy and practicing surgical approaches. But to get the maximum benefit of our training in laboratory, we need the suitable training tools and models that simulate the real situation during live surgery. Such models needs to be developed. Watch for here just to explain. Here using a formalin fixed cadaver with silicone injection, opening the sylvian fissure. You can see that there is something missing. There is no CSF, there is no bleeding, there is no pulsation. Comparing this with using the live cadaver model, you can see there is bleeding, you need to suction, you need to deal with the bleeding. Even though the tissue doesn't look live, but there are something of live surgery, opening the dura and opening the arachnoid, releasing the CSF. All of these things are important simulation that you need to deal with in order to practice and to learn a surgical procedure. Dissecting the arachnoid, exposing the MCA branches, there are the ventricular striate branches, and continue opening the arachnoid. Just here to show you the live filling of the arteries. Now, Professor Yazergil and Sebastian as well called it virtual model. I like to call it live cadaver model. But of course, I don't mean this or this. What I mean is this. I don't know if you hear. So applying some features of live surgery to cadaver model in order to practice live surgery on cadaver specimen. So as you can see here, even experts cannot tell the difference. This is a surgery on a cadaver, clipping an aneurysm. Of course, it's too late to clip this aneurysm in this patient, but it's still informative. Now, how to prepare this model? We clean the vessels, flush them with liquid, with saline, to keep the vessels patent. Then we cannulate the major vessels in the neck, arteries, veins, and also we cannulate the spinal canal, the subarachnoid space through the spinal canal to provide the CSF. Then we connect the arteries to arterial blood reservoir, the veins to venous blood reservoir, and we further connect the arterial reservoir to a machine that produces the pulsating pressure. And also we cannulate the spinal canal to a clear liquid reservoir to simulate the CSF. We provide reservoir to supplement the artificial blood. We can use also, of course, the whole cadaver the head specimen, the leg specimen, or the arm separately. And we can even use an organ. It is using the brain for certain kind of surgical simulation. Now, since 2002, we use application of the model is practice how to deal with complication with intraoperative rupture of an aneurysm. And I bet you most of you will spend the whole residency without even seeing an intraoperative rupture of an aneurysm. So this is the perfect model to practice such complication that might happen with any one of us. So it's better 1,000 times to face this complication in a cadaver rather than facing it for the first time in a live patient. And believe me, sometimes even in cadaver, this situation makes the resident panic. This is, we do this exercise by raising the pressure suddenly, so the bleeding happened, the resident panicked, and he tried to put the clip to stop the bleeding, and he doesn't know how to put the clip. Should he use another section? He is struggling in a cadaver. I think he should call for help. He couldn't do it. Even in a cadaver. So imagine this happened in a live patient while you are by yourself. Other application for this model, we can practice skull fractures and breast fracture. Here is simulating a breast fracture with injury to the sagittal sinus, and you can see the bleeding from the sagittal sinus. So we can practice how to deal with such problem. Now, the model can be applicable for using for other surgical disciplines. Here, using the whole cadaver for surgical and trauma surgery. So we can simulate a trauma patient who just came into the ER with a stab wound in the chest, and the trauma team come and do the procedure, open the chest, and identify the side of the injury. So you can see the left ventricle injury using Foley catheter maneuver. And watch here, while they are suturing, they puncture the balloon of the Foley catheter. So it's a great model to practice and to realize how problems can happen and try to avoid them in the future. Here, practicing injury to the retrohepatic vena cava, using the same techniques, the same instruments that they use in live surgery. And suture the injury site in the same manner in a live patient. Neck dissection, exposing the carotid artery in preparation of nephrectomy. You can see here, while dissecting, you can see the pulsation of the carotid artery. Here, ligating the facial vein. Bleeding happens from the facial vein. So we experience all the actions that happen during live surgery, which make it different from other training models and other simulation. So making the incision in the carotid artery, and you can see the bleeding as if in a live patient. I believe anybody see this without knowing this is a cadaver, he may not tell the difference. Can you believe that? A beating heart in a cadaver in the preparation of coronary bypass. This is the mammillary artery, bleeding from the mammillary artery, and practicing beating heart surgery in the same anatomy of the human being. Also, not only for surgery, we can, when using the whole cadaver, we can use this model to practice central line and arterial line applications. Here practicing subclavian catheter. Also in a trauma patient setting, multiple injuries, the patient needs blood transfusion, so we insert our catheter and get a central line in the same setting of a live condition. Also, as we can use this model with human cadaver, we can use it with animal cadavers for veterinary surgical training. Here, practicing biopsy from the liver, endoscopic procedure. You can see the bleeding from the liver, and this model considered to be a perfect alternative to the use of live animals for surgical training. Of course, we published our work in 2002, and this model has been recognized and cited in the medical modeling and simulation database of the American College of Surgeons. We have a United States patent, and we have the design of a compact device and pump that work with the model, which incorporate the pump with the reservoir in a compact device that make it easy to use. And finally, of course, I would like to thank Professor Yazirji, Mehdi, and Krish for their continuous support in putting this model into life. And thank you very much. Any question about the application?
How fresh should those cadavers be?
You can see it's, of course, using fresh cadaver is the most of the ideal cadaver preparation. But we can still use it with formalin fixed cadaver for certain kind of training, and with TL embalming technique, which keep tissues as fresh as it is.
Is there any approximate cost at this moment for this set of training?
Now, usually the cadaver cost and the extra cost of the machine and the tubing. But if you want to compare the cost in, for example, in this center, we already using cadavers. So the cost of the cadaver is out of that. The extra cost is not more than $300–500 for the extra tubing and artificial blood and the work time for the preparation.
What about technical need? I mean, is there any special?
Any certified anatomist can, anatomical technician, when we teach him, and there is the guidelines for preparing the cadaver. So any certified technician, anatomical technician can do the preparation.
Maybe we can get a cup of coffee and
Thank you.
set up for Dr. Rivas. Thank you very much.